Today was, and I even forgot, so that's hilarious. Today was the deadline for the DVD viewing, the 8-hour DVD viewing of cancer, respiratory, and GI. So yes, I will give you till next Friday. Those of you who asked that question repeatedly, I will give you till next Friday if you want. But seriously, by next Friday, which I believe is the 8th, maybe? What's today? The 31st. The 1st is Saturday. 7th. Okay, so by April 7th, hear me clearly, that is the drop dead deadline for you to be able to schedule to see your GI, your respiratory, your cardio. We are delighted with the interest. That's very, very, very wonderful. Again, I'm doing what I'm doing now. It's just that you're able to see the DVD. It's exactly what I'm doing right now, but it's for GI, respiratory, and cardio. Cardio is 2 different DVDs, so it's actually 2 cardio. One has all your meds on it, the meds for ICU, the meds for cardio, the meds for GI. There's lots of meds anyway. It's, if you think about it, one of the DVDs that you'll see that day is your categories packet, period. I don't know any better way to say it. So you need to bring that with you. I know I tell you to bring it anyway, but you need to bring the categories packet with you because we go over it in fine detail, okay, that day. So that is the DVD viewing. That's for the 24th, which is a Monday. It is part of our spring break. So the only people that will be here will be people here for that DVD viewing. It starts early, but of course you can come later. You can come for any portion of it. I will tell you right off the grip, cardio is in the morning because that's the part everybody wants. So the cardio is in the morning. The GI is at the end. The respiratory part goes with that. Remember, for the respiratory, the issue of, you know, like chest tubes and things like that will be discussed. So that's really helpful for your test. Now, when you combine GI, cardio, respiratory, maternity, peds, growth and development, and of course, next week we start psych, you've covered a lot, okay? So the person who covers that much is someone who we always say, yeah, you've covered a lot of the main aspects of this exam because the exam is very heavy cardio, very heavy with your specialties in maternity and peds lately, you know that. But don't ignore 2 things. Don't ignore neuro and ortho, okay? So if you're someone who's like, oh yeah, you know, that's all I need. No, the neuro and the ortho, they are still really big deals, okay? So we do have a neuro DVD, but I'm just saying when I teach it, that is a major player. Okay, that's that. Now, for if you are new, then you know that tomorrow is, well, you don't know, but tomorrow is OMG, toe-to-toe. Starts April 1st, of course. There are several of you who need to make sure that you apply for your ATT. We're getting a lot of people that don't have it yet. That is something that you lose your seat for, but thank God we don't charge you to come back. Okay, so we don't charge you to come back, but you do kind of lose your seat. Now, in the event, and let me just be really clear about this, because sometimes maybe you don't see it as a lack of integrity, but I do. In the event that you take your test and you fail it and you don't tell us, that's deceit. That is a lack of integrity. And the reason why I bring that up is because every now and then I find someone who that's what they did. Now, how would I know? Well, because we take your application process seriously. When you join this class, you tell us what happened, what you did, what you're doing, what's going on, and then we look you up. And on the Board of Nursing, it clearly tells us how many times you failed. And we write that down, which usually matches what you said. And then what happens is, if during the process of the class you go and take your test before I tell you to take it, that's okay. That's actually okay. I'm not God. Most of those people pass because the exposure to this class is really an over preparation for the test. We over prepare you for this test. And we do that because we're not trying to have you fail. So we over prepare you. But in the event that you take it and we clearly did not think you should, then please be honest with us, because we have to teach you a little bit different based on the number of times you've taken the test. And so it helps me know who you are and how to guide you. And we don't charge you. We really don't. We just say, come on back, sweetheart. Let's do it again. There are so many people sitting here today that will tell you that's exactly what I did. And it just kind of, life goes on. One of my favorite people that did that was Mona. And literally 45 days later, she's a nurse. So the test allows you to retest in 45 days. And for many of you, that's all you needed anyway. Because for some people, they only failed because of anxiety. But if you fail because there's maybe something that you are a little bit deficient in, then please let me love you a little bit longer and kind of guide you in the process. Now, when you just sit down in class like nothing's ever happened and oh well, you know, that kind of crap, that person, once I figure you out, you're going to be charged $750 or escorted out my class. Because if you lie to me, you'll make up patients' vital signs. If you'll make up patients' vital signs or lie to me, then you'll overlook the narcotic count. Or you just ignore the fact that you have impaired nurses all around you. See, the issue is if you'll lie, you'll cheat. If you'll cheat, you'll steal. If you'll steal, there's no limit. Deceit is still deceit. And as you already know, I don't care if it's deceit in a student or deceit in an employee or deceit in a spouse. I can't tolerate it, ever. So I get rid of it. It's a cancer among us. That's why I've been married 17 times. Okay. All right, let's go. Now, so we have the patient that is DKA, and we have the patient that is HHS. So hyperglycemia, hyperosmolar, non-ketotic syndrome. I know that you think about these two, and you now kind of got a better understanding of both, but we still have to fix them. And that's when the easy part comes in. Thank God. Fixing both of them is exactly the same. Fixing both of them is exactly the same. The nursing care for both of these people is exactly the same, thank God. So what I want you to do in your handout, I want you to turn to the part that says DKA. It's towards the back. It says diabetic ketoacidosis. And when we look at the back of this packet with diabetic ketoacidosis, if you walk the page with me, it's kind of easy to see where we're going based on the conversation we had. I'm going to have you use the right-hand side of this packet at the bottom, square it off, and put your HHNS. The treatment is the same, but at least during the HHNS notes in that little area on the right-hand side, you can make sure you highlight what we said. No ketones, no acidosis, no Kussmaul's, no cherry lips, no fruity breath. Just to remind yourself that they're a little different. And lastly, you don't have to be a diabetic to go into HHNS. So diabetes is not necessary to go into HHNS. Those are your highlights about the difference between the two, right, guys? You would agree those are the highlights, because you definitely had to be a diabetic for DKA, didn't you? You did. Okay, so that's it. Now, so let's treat them both, okay? If you treat them both, one of the things is you have to remember that we said both of them were dehydrated. We did say they shared that. We said both are dehydrated. So the number one treatment before you do anything else is hydration. So we're going to start an IV and start some fluids yesterday. But you got to remember something. No LR allowed. Only normal saline. No LR. Only normal saline. So we're going to start isotonic fluids. Give a huge bolus. Bolus means a whole lot of water real fast through that IV. And they're going to have like 1,000 cc's of fluid in them within 20 minutes or a half an hour. Now I need somebody to tell me what that did. What did it do that I hydrated them? What did it do, Donna? It did thin out the blood, the hyperosmolar issue. But what did it do, Ashley? It pushed the potassium back into the cell. It pushed the potassium back into the cell. Put a star by that. It pushed the potassium right back into the cell. Remember what I taught you? I taught you potassium is an issue for the DKA patient. So that was a big deal to push it right back into the cell. Okay, cool. So we hydrated the patient first. And then, of course, we were making sure that we put the EKG on the patient, just because we're monitoring potassium on everybody anyway when you're sick. But we're just making sure we're monitoring. And then you can start an insulin drip. Now, remember, the only insulin you can give IV is who? Regular. You couldn't give intermediate or, long-acting. You got to give short or fast. So you can give the regular or a Pedra or whatever. But you can't give NPH. You cannot give Lantus. All right, now, so we're going to go ahead and start that insulin drip, hang some regular insulin, IV, and we're going to monitor them very frequently, and we're going to be able to turn the insulin pump off once we get the sugar down to what number? 250, very good. Now, you might be thinking, wait a minute, Shell Bell, why don't we want to get the glucose down to normal? Well, we don't want to do that, hell no. Because if we get the glucose down to normal in the hospital and then discharge them home, it's going to drop even more. And now they're going to have the biggest emergency in the diabetic lecture, which is hypoglycemia. Make no bones about it. Hypoglycemia is the biggest emergency on the whole board. It's way more of an emergency than high sugar. Okay, so we're just going to start that insulin drip, get the sugar down to a good 250. That's appropriate. And then we're going to remember that the number one reason for DKA is undiagnosed diabetes. The number one reason for HHNS is illness. Both of them are going to benefit from something called sick day rules. We can avoid a lot of hospitalizations if we give sick day rules. Sick day rules are the rules that we give DKA or HHNS in the ER, and we usually give them even a handout to reinforce what we taught them. And the sick day rules include, number one, never stop or decrease your insulin. So that's one, and there's 5 of them. First rule, never stop or decrease insulin. Sick day rule number 2, check their blood sugar more often, every 3 to 4 hours. Check their blood sugar more often, every 3 to 4 hours. Sick day rule number 3, we tell this patient to check their urine for ketones. We tell this patient to check their urine for ketones. By the way, quick hookup, real quick. Remember it like this. We don't generally see ketones on type 2 unless they're like the hyperemesis gravidarum person. I don't know if you remember that talk. I said you didn't have to be a diabetic to get ketones, but it was very rare. And when we saw ketones in any patient who was not a diabetic, it meant that they had not kept anything down for more than like 3 days, right? It's like you kept throwing up and throwing up and throwing up. That's not what this patient did, of course. But we also said if you're in a state of cellular starvation, you could see ketones. Now, you must go to this test and remember ketones stay with type 1. You must remember that. And you must remember it's extremely unlikely that you would see ketones in type 2. It's very unlikely. But every blue moon, they're so sick. Maybe they had food poisoning. They're so sick that they too were throwing up for a whole different reason. Remember, they weren't really throwing up. Do you remember that? They were not throwing up. We agreed they were not vomiting. But what if they got sick? Like the stomach flu that everybody had going around, where they had diarrhea and they were throwing up. That is an illness, isn't it? And their sugar could go up because of it, couldn't it? So you could get those ketones for a whole different reason, because they were throwing up and they had diarrhea and they hadn't really kept anything down. Now they're no different from like a hyperemesis gravidarum, right? Okay, so don't forget physiology. Physiology still dictates if you've not eaten any food, you're going to get ketones. This patient normally does not have ketones, but we still teach them to check for them. The treatment is no different. The sick day rules are no different. Between the DKA, the HHS, type 1, type 2, that teaching is not going to differ at all. We're still going to say don't stop your insulin or decrease it. We're still going to say check your blood sugar more often, every 3 to 4 hours. We're still going to say get a D-stick kit, we give it to you, and check your urine for ketones. Number 4, if you can't keep anything down, then you need to at least drink fluids, preferably a nutritional supplement like Boost or Ensure. If you can't keep anything down, you need to at least drink fluids, preferably fluids with something in it, like Boost or Ensure. Last rule, because we said there were 5. You need to make sure that you call if that blood sugar is higher than 250 or 300. Some sources say 250, some say 300. You get it. The bottom line is 300 is your limit, right, guys? So your patient's calling us. We do need to know that. We need to guide you and maybe bring you in because you're getting into some trouble. Okay, so that's sick day rules. So bottom line, hear me clearly. Both get hydrated. both get insulin on an insulin pump and EKGs, and both of them get those sick day rules. Now, we typically will discharge this patient and tell them what? Follow up with their healthcare provider within 24 hours, because we cannot sit up here and teach you everything you need to know in an ER. So remember what we do in toe-to-toe. I told you, because I always ask you the same question in toe-to-toe. I give you the scenario. The scenario I give you is based on a DKA ER visit. And then I say, now what's the most important 3 things you're ever going to teach this patient? And then y'all be talking about diet and exercise. I'm like, in an ER? No. Oh, I'm going to teach them how to check their blood sugar and how to read it. And in an ER? No. Oh, well, no, you're not going to do any of that. You're going to tell them to follow up with their healthcare provider within 24 hours, because if it's a newly diagnosed diabetic, you ain't got time for that. That's a lot of teaching, right? And then you're going to tell them to stay hydrated, because between now and tomorrow, they better stay hydrated. And tomorrow they're supposed to have an appointment. So they're going to wake up to make that call to the doctor. I was seen in the ER. I need an appointment. They told me within 24 hours. And the card we give you, the referral we give you, is an endocrinologist on it for you to do that. That's how we do it, okay? So you get it. All right, now, so if you turn to the page where I personally typed it up for you, that page talks about type 1, and it's at the end, it's at the back. It's probably another couple pages. It's not the last page, but it's close. It looks like, yep, it's a chart. It looks like this. I personally typed it for you at the end of the packet, but not quite the last page. Help your neighbor. We ain't got to be here all day. Okay, so look. Everything I said this morning is written right here. Everything I said this morning is written right here. So this typewritten kind of holy hookup is telling you what in the world is happening between DKA and HHS, type 1 and type 2. So when we talk about this in this class, I gave you your summaries. Don't worry too much. You already got it down on paper, okay? Now, here's where I want to pull your attention. You see it says DKA. Be careful. Really read what you're doing on this exam. Sometimes they're mean to you, and they say HHKS. Hyperglycemic, hyperosmolar ketonic syndrome. Somebody else had that?
You know, Eva was saying that you were, but right? That's what they call it. You were, and we were like, which is it?
Yep, HHS. Well, you have to read it, because on this very real exam, they're not as nice to you either. So you want to read it. When you read it, you can't just read the 3 letters. Did they say HHS and then spell out the non-ketotic part of it? Or did they say HHS and say ketones? They're not just going to give you letters. They're going to spell it out. You can't be in such a hurry that you didn't notice, oh shit, this is not HHNS, this is actually DKA. They're very confusing. Look at them. They look alike. They look just alike, except for that one little letter. And sometimes, like we said, they leave that letter out too. So that's why you have to read the entire spelled out version of what it says. Now, that being said, once it says ketones, go with my little DKA, three meanings to the D, 3 meanings to the K, yada, 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 right? And then if it says non-ketotic, then you better roll with the fact that we don't have ketones. And so watch what I did. DKA, type 1. HHS, type 2, or what? Ah, just plain old illness. Okay. Pneumonia, flu, MI patient, stroke patient. That's what I mean when I put that. ICU admit. Okay. Now keep on going. High glucose level. You need to write greater than 500. If you go across to the other side, it says extremely high. You need to write damn near 1,000. The highest Dr. Jones has ever seen, I think he told me he's seen at 1,800. The highest I've ever seen was 14. Yeah, oh yeah. Oh, it's crazy. That's why they die faster. Ketones, large ketones, and acidosis. This guy, none, or maybe minor, like I said, if they got sick from a stomach flu. The next one, Kussmaul's respirations. The other guy only has a fever because the number one cause of the other guy to see you is illness and fever. That's the number one reason they're going to come in, and then you're going to find that crazy ass sugar. Okay? Fruity breath, cherry lips, normal breath odor. Nausea and vomiting, none. Undiagnosed insulin-dependent diabetic is the number one person that shows up as a child usually. The number one reason this guy comes in is illness, fever, or surgery. Doesn't it make sense? Okay, so just know that whenever you get desperate and go, what did she say? It's all right here. Now, that being said, I want you to turn to type 2 diabetes, and she looks like this. It's at the beginning of the packet. Now, I want you to pay special attention to this picture because a picture speaks 1,000 words. She's doing a little too much. Look at that toe. What is she doing with them chocolates? Look at her drowsy look on her face. Maybe it's blurred vision or something, huh? Okay. She's boobalicious, but that doesn't have anything to do with type 2 diabetes. I just noted it. I observe everything. Okay. Open toe shoes. What's going on? Okay. Now, if you paid really close attention, you looked on the floor. She done threw the damn blood pressure cuff down. She tired. She don't care nothing about that cuff. Then she got some antihypertensives and oral hypoglycemics. That's crazy as hell too. Because she don't even have them on the table. She got the chocolates on the table and threw her drugs on the floor. Now, when it says antihypertensive, you need to write ACE inhibitor. Then the dumb butt has a little bubble. What does her bubble say? She wonders. Okay, I'm tired. Okay. All right, now look at this. I just told you this. I said that the type 2 has polyuria, polydipsia, but you don't see polyphagia and you don't see weight loss, do you? Now, let's see what you do see. What you should see is something that says recurrent infections. And what you need to put is yeast infection and UTIs. So this one has a yeast infection, UTIs. I want you to write slow healing wounds. One of your colleagues came up to me after this lecture. Sidewalk consult. I just want to see, I just got a question, Shelly, real quick. Okay, what's this? What's this? What's all this? See this? See, what is all this? I said, oh, well, how long has it been there? It's all these sores. I said, how long has it been there? That's just it. It won't go away. And I'm looking at her personally, and I said, okay, I want you to get your sugar checked. I ain't know that. I know. Just want you to get your sugar checked. Her hemoglobin A1C was 11. undiagnosed diabetic type 2, slow healing wounds, sores. Okay, so I did the same thing with the guy at the drive-thru at the McDonald's. You know, Dr. Jones laughed at me. We carpool on the west side. He said, it's really disgusting that you go to McDonald's and they know who you are. They know your order already. They have everything ready for you. If you say it wrong, they say it right. It's ridiculous. Then I needed him to go one time for me, and he said, he went, and they said, Are you married to Shelly? No, we're not just, no. Are you her new man? No. So they told him, that's not what she wants. She wants this too. No, I have it in my phone, because he's precise. She did not say she wanted that. And they said, but we know her. She want that. Doc, am I lying?
Absolutely. It's crazy. Absolutely.
He was so mad. He goes, they told me you wanted that, but I told them you didn't put it in the list. I told them you didn't. They said you did. All these old people looking at me like Shelly wants that. It was so sad. It was ridiculous. So I'm telling you that the guy at the drive-thru had all these sores on his arms. And these are my family in McDonald's. They're my little family. So I said, what's going on? What's happening with you? Now I've been watching you for a while. You got all this shit on your arms. What's going on? Oh, no, I just scrape up against shit. I don't really know. Really? This is what I want you to do, baby boy. I want you to go ahead, get a little appointment with your doctor. Tell him to check your sugar. Man, you're the shit, man. We love you, Shelly. I was a diabetic and didn't know it. Okay, so so you want to remember slow healing wounds, sores don't heal, UTI, yeast infection, yada, yada, yada. Now, the visual changes, be very careful with this. I tell you to think of it like this. If you have double vision, your sugar's low. Double equals low. But when you have blurred vision and slurred speech, because of the stroke you're having, you can have a high sugar. Blurred vision is high. So you're having blurred vision because your sugar is syrupy, right? Syrup and blurred. Double and low. You see two of everything, your sugar's low. Double equals low. Blurred is high. So it says visual changes. Fatigue and energy, you get that already. You're okay with that. That's cool. Now, her face looks like she's so tired. That's the whole fatigue, the lack of energy. Because you're just really sick and you don't even know it. Now, the labs, OMG. Take out your OMG packet and let's look at this lab in particular because you get confused on it if you're not careful. In your OMG packet, you have your critical labs, and students get confused on this all the time, especially you guys, because it's kind of like hard to remember everything you need to know. So if you look at your OMG packet, you will see there's several different things. You'll see it says hemoglobin A1C less than 7 for monitoring, A1C for diagnostic is 6.5 or higher. And then, of course, you have to make sense out of both. Here's what you better know. If you come in any given day of the year, and it doesn't matter what you ate, remember that a hemoglobin A1C, you don't need to fast, right? There's no need to fast for a hemoglobin A1C. I could do every single one of you right now, and it's extremely accurate. Do we agree? So if that's the case, and I do every single one of you right now, and it's very, very accurate, every single one of you with the 6.5 or higher, you have diabetes, period. Once I've diagnosed you with diabetes, now we have a whole different yardstick to monitor you for the rest of your life. If I am monitoring you for the rest of your life, which I would imagine I would be if you're diabetic, then I need you to, at all times, keep your hemoglobin A1C less than 7. Do you see the difference in those two numbers? It's so close, but yet it's different. Now, that doesn't do you any good if you don't know what normal is. Normal hemoglobin A1C is less than 5.5. Normal hemoglobin A1C, God bless you, is less than 5.5. So once you hit 6.5, you're a diabetic. Once you have diabetes, in order to preserve your organs, you better keep that hemoglobin A1C less than 7. That's called monitoring. We're trying to monitor this person. They get this test every 3 months, don't they? And every 3 months, we're trying to make sure you keep that hemoglobin A1C less than 7. Does that help a little bit, decipher between those two? Now, we usually have to do more than one test because in and of itself, one test doesn't really help me. But I can tell you out of all the tests we do, this one's the most reliable. So once I do a hemoglobin A1C on any one of you and I get a 6.5, I am very comfortable telling you that you have diabetes. I'm going to do more testing just to confirm that you really do. But my God, this is not something I see lie to me. It is definitely a very reliable test. Now, what other tests might I do? Well, I could do another hemoglobin A1C in another month. And if it's higher than 6.5, it certainly confirms that you're diabetic. I could do a fasting blood sugar. Let's look at fasting. Fasting's important too. When we look at a diabetic or somebody we think might be a diabetic, if we look at the fasting blood sugar, you have to have fasted for 8 to 10 hours. When we do this fasting blood sugar, we need you to be less than 100. So if you look at this handout, it says that. Look at the handout, roll with your girl. It says pre-diabetes, fasting blood sugar 100 to 125, which should tell you that normal is less than 100. Because pre ain't normal, is it? Okay, so a fasting blood sugar normal is less than 100. A fasting blood sugar that is pre-diabetic, also called metabolic syndrome, is 100 to 126. A fasting blood sugar higher than 126 on 2 separate occasions is diabetes. And I'll say that again. On 2 separate occasions. So you definitely can't go by one fasting blood sugar and call somebody diabetic. Not so much. You have to have it on 2 separate occasions. And one of the reasons for that is because illness makes it high. We just discussed that. Okay. Now, the next thing that you want to be worried about when you look at this handout is the bottom says metabolic syndrome. In this box off to the right-hand side is metabolic syndrome. This box right here is metabolic syndrome. I teach an easy way for you to remember it. Here's how I teach it. I already have the lines up here for you to remember. I tell you high BS, high BP, high BMI, and high triglycerides with low HDL. Now, it should say that. In a weird sort of way, it should actually say that. And it does. It says high triglycerides. It says low HDL. It says high BP. It says central obesity, which is high BMI. And it talks about your blood sugar being high. But it's a lot easier to remember 3 B's and a high of triglycerides with a low HDL. So this is the way I make you remember it. One of the ways I get you to understand it, which is totally different from remembering it, one of the ways I get you to understand metabolic syndrome, and what you want to do with that is turn to this page in the front. The way I get you to understand this condition is I tell you it's a type of pre-diabetes. It's a type of pre-diabetes. So, if you look at something considered to be pre-diabetes, you know if we don't get on top of this, we're going to have diabetes. Common sense. So the complications of metabolic syndrome are going to be the patient is at risk, it's at the top, of diabetes, stroke, heart disease. And I kind of do it like this. I tell you, CVA, CAD, CKD, keep all my C's together. This is your stroke. This is coronary artery disease or heart disease. This is chronic kidney disease or kidney failure. Okay, so you better know all of these. And of course, this is obviously pre-diabetes. That's what I call it, because it is going to lead to diabetes if we're not careful. As nurses, if we could catch everybody in this state, we would prevent all type 2s. And we can catch everybody in this state if we care to look at it and address it. Okay, so let's look at this metabolic syndrome, because it's very, very interesting in terms of what exactly are we saying when it comes to BMI. If you look at the left-hand side, we're talking some BMI issues. What is BMI again? Body mass index, okay? When we look at BMI, we know that ideal is what again? 19 to who? Some of y'all got that wrong. 19 to who? Obviously not. As you shout it out even louder. Okay, 19 to 24 is ideal. Ain't nobody in this room, include me, there. So that's all right. So what? 25 to 29 equals what? Overweight. So greater than 30 or equal to it equals what? Okay, so you can bet your last dollar the type 2 diabetic is overweight. At least they have a BMI greater than 25. Okay, now where is their weight? And this is so interesting. When a patient reaches a certain age, the distribution of their fat and their weight is going to go to a different area. If you look at these people, they look like weeble wobbles on your sheet. Only the old will understand that comment. And if you do, that's a shame. If you're young, that's sad. Okay? So if you're young and you know what a weeble wobble is, we're going to pray for you after class. But weeble wobbles were these little toys that just kind of weeble and wobble. Okay? So I don't know where these people's feet are, but they're gone. But what's going on with these people is their belly is huge. Now, here we go. Some of y'all remember back in the day a song by the Commodores called Brick House. And in that song, he said, 36, 24, 36. Do you remember those measurements in the song Brick House? Okay, that's important because the first 36 was her breastises. The last 36 was her hips. What was the 24 supposed to be? That was supposed to be her damn waistline. What is your handout saying the waist is? They got their numbers mixed up, huh? Well, here's what you want to know. If you can do this, and you should, because I have, if you take a measuring tape and measure with your belly button being the landmark, you measure around your waist. Your waist was not supposed to be the same size as your breastises and your hips. You were supposed to have like an hourglass shape. Remember, that was supposed to be what was going on. And so you were supposed to have a little hourglass hula hoop. Remember, y'all? Y'all remember that? Okay. You weren't supposed to have all this shit all the same. Boobs, bob, bob, bob. That wasn't how it was supposed to go. Okay, so what you want to remember is that technically you weren't supposed to look like the house. And what happens with metabolic syndrome is you look like the house, okay? Now, for men, in case the guys in here think they off the hook, I know you thought you was off the hook, right? I'm all on the breastises and shit. No. We coming up your street and down your parking lot. Let me tell you about your men. Men, it's not good for my grandchild to ask you, are you having a boy or a girl? That's not appropriate, okay? So you got the big beer gut and all this here shit. You just as crazy as we are with the apple shapes, okay? So what you want to remember for women, there are two types of women. One is apple. The other one is a pear-shaped woman. It's the apple-shaped, which is bigger at the top, more narrow in the hips, that is at risk for heart disease more. It's the pear-shaped woman that is at risk for reproductive cancers. Okay, so these are two different things, but they are important for you to know on this exam. The apple shape is cardiac disease, that's top heavy. The bottom heavy is reproductive cancers. So if you are more apple-shaped, you are more likely to have metabolic syndrome. In this situation, with the BMI greater than 25, central obesity, which has also been called truncal obesity, because you're obese around your trunk, truncal obesity, central obesity, kind of like the guy with Cushing's, right? Remember, he had truncal obesity too. So this patient, that's one of our issues for metabolic syndrome. Now, here's the thing as you go around this page. You only need 3 to have the diagnosis. You don't even need all 4. So let's go around the page because we might have another one going on around here. Hyperglycemia. Be very careful because they made a typo. They have on there 110. Oh, you ain't doing it like that. We said greater than 100. So cross the 110 out, put fasting blood sugar greater than 100. Or they're on some kind of diabetic medication. Maybe they're on metformin. Maybe they're on glyburide. Maybe they're on whatever. Okay? If they're on one of those, that's just as sufficient as a fasting blood sugar greater than 100. Either one of those, they met the criteria for that issue. Okay? Let's keep on going down. Hypertension on the left-hand side. Be very careful with this one. This is why I want you to be very careful with this one. Because you may have learned over the last few years in school that the definition of hypertension has changed a little bit. We have something called pre-hypertension, and that is your blood pressure is greater than or equal to 130s over 80s, and then we have something called stage 1, which is greater than or equal to 140 over 90s. So if you are in here or higher, you qualify for this disease. And you can see, or if you don't have the blood pressure in the office of this, even if you're just on blood pressure meds, that qualifies. Okay, so you see that on here. The last one is this whole lipid thing. Lipids are confusing if you don't know my trick. So we teach you the trick. Here's our trick. Our trick is HLT. This is called highlight. It is my way of teaching you how always to remember your cholesterol labs. Highlight. HLTT. Okay? I teach you that each one of these letters stand for something, but that we actually have to work backwards. And I have to ask you before we work it backwards what most of you should know. What should a total cholesterol be? Less than what? 200. To get this right in your spirit for this test, you've got to take this number and go down by 50 each time. So I'm just going to plug in the numbers based on what I just said. I've got to go down by 50 each time. So this T stands for total cholesterol. This T stands for triglycerides. So I'm saying to you that your total cholesterol should be less than 200. Your triglycerides should be less than 150. And this L stands for low down dirty dog, LDL. Your LDL should be less than 100. And then we get to this H and we change up some stuff. We know that this is your HDL, and we have a trick for that. We say it's happy when high. Not high on reefer, just happy when high. So we cannot use the less than sign here. We have to use the greater than. This is how you remember them forever, your lipid profile. Because I've remembered it since Ursuline. I don't have to look it up, I just remember it. Because I tell you the mnemonic of highlight. This is in your Oh My God packet, if you care to look at it. You know how that goes. So it's in there already. It's already in there because these things are important for you to know. So I put them in little pink packets called an Oh My God packet. Total cholesterol, less than 200. Triglycerides, less than 150. LDL, less than 100. HDL, greater than 50. So it's in there. So the patient with metabolic syndrome has this one and this one as their main problem. So if you look at it, their HDL is super less than 50, isn't it? That's a problem. Now, I had a lipid profile before myself years ago when I was teaching at Bally's. Remember that story? Okay, so my friend, Linda Bradley, a very close friend, and my doctor at the time, she did my lipid profile, called me, cussed me out, you know how that is. She said, girl, your cholesterol, well, she didn't even do my lipid profile. She just did my cholesterol. Your cholesterol, 265. Get in here and get this lipid panel done. Now, what you got to remember for this, 10 hours fasting, not 8. 10. So I had to fast for 10 hours. When she got done singing and dancing and cussing me out, she commended me and said, okay, I'm going to leave you alone. Because as it turns out, once we did your fasting, you're normal. And not only that, your HDL is 71. Why? What raises HDL? Exercise. I was teaching every day. Teaching a lot of classes every day in Bally's when I was at Ursuline. So your exercise will increase your HDL. Now, Uh-oh. What lowers LDL? Just a quick question. What is it? Somebody said it. What kind? Excellent, Christy. High fiber. High fiber diet literally decreases your LDL because fiber attaches to cholesterol and takes it right out of your body. So the highest fiber, easy food you can incorporate in your life is eating an apple. That's the easiest way to get your fiber. Now, I guess you could put some raspberries in your pocket and keep it moving, but an apple's easier because raspberries are very high in fiber also. But it's just easier for me to pack an apple or a pear. Pear or an apple, boom, you got all the fiber. This is not hard. Your patient needs to know that's that easy. An apple or a pear, boom, you got your fiber. Okay, whole wheat, obviously. Cheerios, oatmeal, obviously. But I'm just saying easy. Now, you can't peel the peeling off the apple. You just screwed that up. You got to take a real apple. Okay, so, and not that garbage at McDonald's. Because that's got preservatives. I wouldn't give that to my kid if you paid me. You want to know how I know it got preservatives? Leave it on your back seat in your car and come back 2 months later, like my grandchild did. Still white apples. What color does an apple change? Brown. How fast does it change? Within an hour. Okay. Triglycerides. Less than 150. You got to know this. You got to know. All right. Now, so what we're going to do about this patient? Well, this patient, I teach you M&M. Metabolic syndrome, metformin. M&M. Metabolic syndrome, metformin. That's what we're going to do with this patient. Metabolic syndrome, metformin. M&M. We're going to make sure the patient is on a Mediterranean diet. See, I told you M&M, metabolic syndrome, metformin, Mediterranean diet. It's not that hard, okay? M&M, metabolic syndrome, metformin, Mediterranean diet. Now, that don't help your little ass if you don't know what a Mediterranean diet is. So what's a Mediterranean diet? Oh, I heard that, Christy. Some of y'all are alcoholics, and y'all said the wine first, but I would hope that you did it like this. High, 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 and low. So here we go. High fruits and veggies. High fiber in the form of grains. High olive oil. And honestly, the olive oil is one of the most important things on the list. You do? Okay. High fruits and veggies, high grains, high olive oil. Oh, wait, we got one more high, which is kind of cool. What was the one y'all love? See. Red wine. Okay. Listen, you alcoholics. This red wine is just as easy to get in the form of red grapes. So what is wine made of? Grapes. So before you go out here and get a DUI, get a handful of grapes instead. You'll be safer. So, because some of y'all take this a step too far. Why is you drinking a bottle a day? Okay, it wasn't that serious. So Mediterranean diet, fruits and veggies, fiber and grains, olive oil, fish and chicken. I did not say Popeyes. It is not the same thing. Okay, I did not. I said fish and chicken, preferably baked and all that good stuff. Okay, now, This is what the Mediterranean people do, and they have the best statistics in terms of their health status. Where do they live? Greece. Where else? Italy. One more. France. Excellent. France, Greece, and Italy have the best statistics. And this is what their diet is. And over 20 years, they've been studying these people with this type of food. And you got to remember what else they do. They get off the freaking couch. They walk and they bicycle, okay? Now, that helps, of course. We know that exercise is going to increase your HDL. But that's what you do for this patient. What else might help this patient? Well, HCTZ and statins. What is HCTZ? How do you spell it out? What is it? Hydrochlorothiazide. HCTZ to keep the blood pressure low and the fluid off the body. HCTZ. And what about that statin? What was that for? That was for your cholesterol. So if we had to give drugs out, the drug names would be metformin, hydrochlorothiazide, and this statin drug like Lipid or something like that. Now, we don't like drugs. I told you that before. We would rather not do drugs. And that's the whole point of this handout. The whole point of this handout is that if you can catch your patient in metabolic syndrome before you get to diabetes, they can be treated with no drugs. They can be treated with the Mediterranean diet, exercise, walking every day for 30 minutes, okay? If they can just do that, that's a lot better than slipping them drugs. We don't want to do drugs if we don't have to. And on this exam, you had to know that a diet and exercise was more, get this, more effective than those drugs. I'll say it again. For metabolic syndrome, diet and exercise was more effective than the drugs. Now, you had to teach portion control. Why do we keep supersizing every damn thing? Portion control. My daughter went to China. She said even their servings at McDonald's are smaller. Yeah, at McDonald's there's no such thing as no 20 in China. No, and the regular size is four nuggets. Yeah, their sizes are so much smaller in the Philippines too, I think she said. Yeah, so they don't understand the super size. They don't understand it at all. So portion control, that was on there. Portion control. Okay, now, so you should be okay with that. Let's go to the next page. And if you go to the next page from there, you should see a couple pages maybe in. Look for the diabetes mellitus type 1. Find her. She's going into the bathroom. Find her. It's a couple pages in. Y'all see her? Okay, I got a problem. Why is she going to the damn bathroom with a pop and a burger? That's trifling. You know better than to eat in the bathroom. That's just the nastiest shit I've ever seen in my life. But we're going to try to roll with her, y'all, because she is somebody you got to know. Look at the Select All. It's a wonderful Select All. It's a delightful Select All. It's the bombdiggity.com Select All, and I've already discussed it with you this morning. We said polyuria. We said polydipsia. We said polyphagia, and we damn sure said weight loss, did we not? Oh, okay. So y'all cool on that. I ain't got to spend all day there. So what else do we have? Well, first of all, we're tired because glucose is energy. Second of all, we too have that frequency of infections, so you know what to do with that. That's called yeast infection, UTIs, and slow healing wounds. You already knew that. Rapid onset. This morning's demonstration, I told you it happened all of a sudden. The pancreas was looking for their insulin, they ain't seen none. It happened all of a sudden. You need to put autoimmune and destruction of beta cells. We are insulin dependent. You already knew that. That was part of your 3Ds of DKA. You knew that we were a child, but you need to write something extra down there. You need to write usually less than 30 years of age. So anytime before 3 years old, you could have, 30 years old, you can have this easily. Now the familial tendency, I want you to put something else right there about familial tendency. Just put genetic. Put your genetic. And you have some room on that page at the top. At the very top, put DKA. This is a patient that has the DKA. Okay? At the top, you're going to put macrovascular and microvascular changes. Macro and micro. Macro and micro. Okay? So you can see there is a big difference in her size, if you look at her, in her size and the other lady sitting in the lounge chair eating chocolates, can't you? Okay, so then on the other hand, if you want to really think about what kind of macro and microvascular changes they have, I want you to turn to this page towards the end that talks about triangle of diabetes management. Triangle of diabetes management. And let's sort out our macro from our micro. It's going to be interesting.